So I'd like to welcome everyone to the last webinar in our three-part series celebrating International One Health Day. I'm Dr. Cassidy Rist, an assistant professor in the Department of Population Health Sciences here at the Virginia Maryland College of Veterinary Medicine. I'm also the faculty advisor to the Student One Health Working Group, which is made up of about 12 students representing all three of our college's degree programs, including veterinary medicine, public health, biomedical, and veterinary sciences. Our working group also has student representatives from the Virginia Tech Carilion School of Medicine and the Edward Via College of Osteopathic Medicine. So the purpose of the student working group is to host events and activities like this one that support communication, training, and learning across human and animal health professions. So in tonight's webinar, we have two guest speakers from organizations that work with vulnerable populations. They will each have an opportunity to talk about the important work that they do, which will then be followed by some moderated questions where we'll learn about how the COVID-19 pandemic has impacted their organizations and the populations they serve. Finally, we'll have time at the end for questions from the audience. Please note that this webinar has live captioning, which you can access using the button at the bottom of your screen. There you'll also see a Q&A button that you can use to ask questions of our speakers. So feel free to ask them as they come up, and our moderators will get to them at the end. So to get started, I want to go ahead and introduce our student moderators for tonight's webinar. Both are members of the One Health Working Group. I'd like to start with Memi Pearsall. Memi is a second-year DVM student from Richmond, Virginia. Her career goals are to pursue an internship and residency upon graduation and eventually use those skills to work or volunteer in shelter medicine. Thank you, Memi. Our second moderator is Jackie Abramson. Jackie is a second-year MPH student with a concentration in infectious diseases and health education. Her career goals are to address health disparities in at-risk populations and infection control and prevention through community outreach. Jackie spent her summer working with the Virginia Harm Reduction and the New River Health District, helping to create their COVID-19 response to better serve the population during this time. So she's perfectly poised to introduce our first speaker. Take it away, Jackie.
Thank you, Dr. Rist. So Lawson Koeppel is our first speaker, and he received his Master's of Social Work with a focus on substance use, policy, and mental health in 2019. He co-founded Virginia Harm Reduction Coalition in 2018 to prevent overdose deaths and empower people who use drugs. So Lawson will be giving a brief introduction to his organization and the work that they do.
So hi, thanks, Jackie. I appreciate that. And I appreciate all the work that you've helped us with over the last tumultuous year that we've been working in this environment. My name's Lawson. I'm Executive Director of the Virginia Harm Reduction Coalition. I have a slide deck, and I might have kind of messed up the directions at this point. I was going to kind of walk through a little bit of what our organization does and kind of the response that we've had based on COVID. Is that still a function that I can access as far as sharing those slides?
Yep, that should work. You should be able to do share screen.
Hold on. Thanks for your patience. All right. Is that showing up for everybody?
Yep, looks great.
All right, good deal. So that's kind of us in a nutshell. Virginia Harm Reduction Coalition, for those of you who are familiar with harm reduction and the reason for its existence, we are a pretty basic harm reduction program in that sense. The big difference for us is that we are peer-led and peer-organized, so it's a mutual aid endeavor. And I think anybody in the state of Virginia kind of understands the need for harm reduction. I know that COVID has the headlines, and we're going to talk a little bit about what we've done with each of our organizations with that kind of overshadowing all of the work that we do. But the thing that hasn't gone away are deaths for people who use drugs. And each of those are policy failures and unnecessary deaths and preventable deaths. With some pretty basic medicine and outreach. So that's what our endeavor is to empower people in our community to be able to protect their health, whether that be with sterile implements or protect their lives, if that's with naloxone hydrochloride, which is also known as Narcan. In addition to our core harm reduction services, we also offer patient navigation through a CDC grant. So, and that's materially changed the things that we do in the office and during outreach. We're able to get folks into enrollment for basic services that they need. The big one this spring and summer has been the unemployment insurance, helping folks with that. And we're, about 53% of the folks we work with are unhoused. So getting that unemployment really materially changed their lives. And so we worked to do that stuff. We also do advocacy at the state level. We were able to work with a coalition of folks across the state to help implement, trying to find the right word for this, more sane legislation that allowed for the operation of programs like ours, and to help people who call for help during an overdose not have to worry about prosecution, which was a problem with our Good Samaritan law up until July 1 of this year. That work has shown real benefits in lives. From 2018, 2019, our distribution in the footprint that we're in Southwest Virginia decreased overdoses for the first time in 3 years. And that was in when the entire state was going up 9%. So we had a huge impact getting that medicine out to the folks who need it, people who use drugs. Obviously, this year has changed things. Just got the second quarter information about the mortality rate, and just kind of focusing on one municipality, looking at, say, Roanoke City. We lost 11 more people in 6 months of 2020 than we did in all of 2019. So we're playing catch up. I think there's a lot of factors and a lot of things we can talk about later as to why that's happened. I do know that this spring we had about 500 individuals enrolled in our programs, and now we're going to hit 1,100 here by the end of the week. Those reversal numbers are based on CDC data. I think it's 17% usage for community distribution. In all likelihood, that number is actually higher based on the total amount of medicine that we got out. I was going to talk a little bit about, go ahead and share a little bit about the work that Jackie was involved with in our response to COVID for our population. And the reason why it started becoming important to us was we saw early on, folks with means who could travel having the virus. And, we could see the later it got down, the further it got down into the folks that we worked with who were living in congregate living, that as soon as it hit those places where we've got folks who are packed 12 deep in hotel rooms, that was going to be a real problem. We also started getting a lot of early information on how COVID attacks body systems, and how those interactions and those body systems interact with the substances individuals use. And that's kind of the breakdown here, looking at the different substances that folks use, the body systems that are involved in that substance use, and how COVID kind of exacerbates things. And when we're looking at a virus whose headline is respiratory systems, and you're looking at overdoses from opioids, which are respiratory failures, you obviously have a huge addition to a problem that was already unmanageable in our state. So we saw those two things and we were like, well, we've got to put together a plan. We were working with Dr. Pearsall down in the New River Valley, where Jackie was, and we all put together a proposal and said, hey, what we need to do is start with all of the drive-through testing was going on. And we knew, again, that most of the folks we worked with, number one, don't have a car. They don't have notifications to even get to these if they need to walk up to them. And we were already doing outreach. So we said, all right, so we need to find a way to put this together for our folks. So we partnered with New River Health District, the Roanoke City and Allegheny Health District, and Beth O'Connor at the Virginia Rural Healthcare Association. We put together a proposal based on the science that we saw early on, our concerns, and kind of what we were looking to do. And basically what we're trying to do is at least slow the infection rate in a community that we saw as very high risk. And that wasn't getting a whole lot of, I think, attention, and still isn't getting a lot of attention. So that's why we put together the program we did. And so these are some photos. Jackie's, if you can see her bottom right of the top photo, bottom right-ish of the top photo. What we did is, and she was instrumental in getting a lot of the pieces to this program together. We had a huge group of folks down in the New River Valley who were making masks for community organizations and for individuals who couldn't afford them or didn't have access to them. They donated, I think, more than 300 of those homemade masks that we were able to distribute to our folks. In addition to that, we got the HHS, Health and Human Services masks. We had a huge donation from Dr. Bronner's, that gave us soap and hand sanitizer. We also had locally sourced hand sanitizer from Appalachian Stills. We put together as much education on substance use, sex work, and COVID, and how those things interact so that we could help educate folks. And we put those priorities together on the people we were going to test based on that thinking. What we had was a situation here in Roanoke where the municipality had designated a certain agency to house folks who were positive, especially folks who didn't have places to isolate. The problem was that place had some pretty strict requirements for people who were staying there, like not using drugs. That becomes a hurdle and a difficulty for the folks that we're serving who do need to isolate, don't have the means to, and are going to continue to use the substances that they use. So we had the ability with VHRA, Virginia Rural Healthcare, VRHA, to be able to put some folks up in long stay apartments with kitchenettes so they wouldn't have to leave, be able to provide them with food, basic supplies, and a stipend for any kind of income loss they had. I was trying to update the results on what we've done so far. These numbers are estimates at this point. We've gotten out a lot of masks, a lot of sanitizer, a lot of soap. That 250 is probably low. I was in the office all afternoon doing testing with groups of folks. So that number continues to increase. And the local health director on a phone call last week said, hey, can you get back out and do some more testing? Because we had slowed down. The reason we slowed down was for that top bullet point. We'd only had 2 positive cases up until October. And I was doing a presentation with another doctor in Baltimore who ran a similar program. And it turns out those findings in people who are unhoused weren't rare across the country. We weren't finding people that were positive for the infection. There's a lot of reasons, we hypothesized, and a lot of it though around the thinking is those folks aren't intersecting with vector points where transmission would happen, especially in healthcare settings. The folks that we work with don't go into a clinical environment unless it's literally life or death because of stigma and their experience with healthcare in those settings in the past. But we are looking to pick that back up because as we've seen, I think in local media reports here in Southwest Virginia, those cases are starting to spike. And we can come back to this. This is some of the work that Jackie did with a survey of folks, did a kind of a sampling of the people that we serve, kind of looking at where their priorities were. And I don't think these are really any different than the folks that I see on a regular basis, say at Kroger. We've got folks that adhere to it, folks that don't. And I think, nobody's interested in wearing a mask. I certainly am not, but I have to, based on what's going on. We did find folks who were using the hand sanitizer and the soap that we handed out. The masks had a little less enthusiasm, but they were being used, I think mostly in situations where they were required and not necessarily in casual interactions. And then a lot of mixed results about being tested. Having been tested several times, I'm not a fan of it, so I understand the mixed results across the board. And folks at the end of the program were at least washing and sanitizing more.
Dr. Geller? Or I'm sorry, Lawson? Lawson, I think we can't hear you. Can you hear us?
Can you hear me now?
Yes, okay.
So at this point, I don't know who to turn it over to. That was the quick summary of what we've done and our approach to what's happened in 2020.
I think I can go ahead and introduce Dr. Geller now. We're really excited to have Dr. Geller here today. He graduated from CSU College of Veterinary Medicine in 1995 and became board certified in canine and feline medicine by the American Board of Veterinary Practitioners in 2010. After working as an emergency veterinarian for 20 years, Dr. Geller is now the founder and national director of the Street Dog Coalition, which provides free medical care to pets of those experiencing homelessness. And the Street Dog Coalition has volunteer veterinary teams in over 40 US cities. So take it away, Dr. Geller.
Okay, well, thanks so much for that good introduction. Also, that other great presentation. I think there's a lot of overlap between our groups, so I'm looking forward to sharing that with you. And I'm going to, I've also got a little, what's going on here? I've got a little PowerPoint that I put together, and gosh, I started getting into this, I call it street medicine, the street medicine work, and there are so many issues that have branched out that it's going to be really hard for me to touch on them all, but I'm going to try to focus on the ones that seem to be relevant here. But for me, the issue is we see these folks living on the streets, mostly in bigger cities, and realize that their life is already hard. We already know that. And then by having these pets, it's made even harder. They've created more barriers for themselves, but they've also enriched their lives in other ways that would be hard to replace, any kind of social services or even financial financial support, because I think we all know the value that pets can have in a person's life. Taking a quick look, luckily I've gotten to travel around to some different cities and see what's going on this summer. And here in North Las Vegas, this is actually a couple years ago, but this fellow's still around. We see this fellow carrying his dog Lucky around, and everyone thought this, was pretty cute. And he mentioned lots of pictures. He mentioned to me that he walks 7 or 8 miles a day, which is probably pretty typical for someone living on the streets. But Lucky can walk for about 1 mile, then he has to carry him. So he has to carry him. And that's because, as you can look at this picture, Lucky a little bit blurry, but he's got that angular limb deformity on his right front foot. It's angled way out, that Barrett's condition. So he's just going to have to live with that. And I think at some point, Lucky probably may not be able to walk much at all. And this population we're working with, everyone knows this also, is they're pretty much broke. So all the programs that we have for low-income veterinary clients just don't work here. Pet insurance, care credit cards, etc. Even family and friends really aren't accessible to help these folks. Here's a quick overview of what we do, and you'll see kind of how we've branched out. So those dots show where we have purple dots show where we have volunteer veterinary teams in different cities. Sometimes we have multiple teams in one city. The green dots are where we're trying to get set up. So we always have some veterinarian that's interested in doing it. We're not actively recruiting because we're trying to slow things down a little bit, because myself and our operations person are trying to coordinate everything from Fort Collins, Colorado, where I live. So basically, you know, our main effort is doing these street clinics out on the street. We set up tents, tables. Sometimes we'll go into encampments and actually do the work there, working more out of a backpack model than a street clinic. Sometimes we'll get to go inside a homeless shelter. And that really is nice because we get out of the elements, kind of take that out of it. But otherwise, we have open tents. We have some enclosed tents that we are even good in the wintertime. We can heat them. We can put lights in them, etc. We do things like virtual spay neuter. So that means in addition to treating these pets medically, we can give them a voucher for a free spay or neuter for their pet. And then we have to figure out transportation. We have a special focus on homeless veterans. We'll show you a few pictures later. You know, we handle it if we have a really sick animal where it's just doesn't make sense to keep going. We'll make sure they get euthanized humanely, take care of aftercare. Occasionally we get pets that do need emergency care way more than what we can provide in the street. We're scraping up dollars for that. We've learned that the women that are living on the street, I mean, they're so tough, and these dogs are so important to them that we also make a special effort to take care of them. And then we've gotten involved in homeless shelters. We did a big study of homeless shelters in the United States. One of our CSU vet students contacted over 750 homeless shelters in the 100 biggest cities, and only 6% of them allow pets in there. So we're trying to work on co-sheltering, making shelters pet friendly. That would also apply to addictions and rehabilitation facilities. People go in for 30 days. Ideally, they take their pets with them because I think they can help with healing and maybe even with other people that are in there. But if not, we're trying to set up foster care and boarding options so their pets can be taken care of. Probably the most exciting thing that's going on right now is the last two things is we're teaming up with medical schools, and it sounds like you guys are already doing that there, so that's great. But CSU here in Colorado just opened a branch of the CU medical school. So we have a small group of medical students in Fort Collins that are now joining us on our weekly street clinics at the local homeless day shelter. And we're also bringing in social work folks and mental health professionals as well to try to create this team approach. And we'll talk maybe a little bit more about the outreach we want to do, hitting other areas of the state, and then heavily involving vet students in lots of different campuses where we're even trying to get them involved in some street clinics, trying to set up some street medicine clubs or even teams at those schools. Here's a picture of our social worker on the left, Fred. And the reason I'm showing this picture is that this park behind him was temporarily an outdoor encampment when they had to shut down all the homeless shelters this summer for COVID. And we realized that there was no outside place for anybody to wash up. They're living in all these tents. They had a couple of porta potties, greatly underserved. They weren't really clean, and there was no outside running water. And the inside building closed at like 6 o'clock at night, opened at 8 in the morning. So from 6 at night to 8 in the morning, no outside running water. So this is, of course, our very primitive hand washing station, and it would actually involve 2 people to wash your hands without one person touching it. Then we worked on some more sophisticated models with a foot pump, et cetera. So we think this is a real important component of what we're doing outside, but especially with COVID. So I'm trying to touch on that a little bit. So well, on the right just shows, instead of doing our weekly street clinics, because we had no place inside to do them this summer, we just worked out of the back of my truck in a parking lot and threw out a table or 2. We use those as separators. I'll talk a little bit more too about that to try to keep it COVID safe. We just felt like that these pets needed attention and care, and COVID, even though it's a significant risk, was not enough of a risk to us that volunteered to be out there to stop us from doing our work. You may know some of these numbers, but even though there's only about 560,000, maybe last year counted, there's probably closer to 1.4 million by other estimates, and about 1/3 of those folks are sheltered. Are unsheltered, and 2/3 are sheltered. So we're focusing mostly on the unsheltered folks, but definitely aren't limiting ourselves to them. If about 10% of these folks that are experiencing homelessness or at risk of it or in and out of it, you know, there's probably about, we think of close to 100,000 pets that our group has going to be trying to take care of. And of course, there's other groups taking care of them too. We're not going to do it all. Here's a recent clinic. I think these pictures say way more than what I can say, but this is our first clinic in LA, Skid Row. And these are folks that are waiting. And because of the emphasis on this talk today, I think is COVID, I just want you to notice things like social distancing and mask wearing, because this is a high risk environment because these folks are more susceptible to COVID-19 because they have underlying medical problems that haven't been adequately addressed. So we know it's a high risk population. Here's a little bit of our One Health work with Michigan State students down in Detroit at a homeless shelter there. What I wanted to show you about this picture, second picture off on the left there, you can see Detroit Street Medicine. So these are medical students, and I've zoomed in on that picture on the right now too, doing exactly the same thing as we're doing right next door. And to us, this is what One Health on the street should look like. I'll show you some more pictures of that too. So I was in Nashville in July. There's all this stuff going on in Nashville. There's protests, there's Black Lives Matter on the other side of this plaza, but these folks are just kind of trying to survive. And I noticed there was definitely some disengagement, even though they're all in the same general location of all these things happening on the streets. Notice the mask wearing isn't looking that great here. We do require them to wear masks. We give folks masks, but when those masks get pulled down because someone thinks you can't hear them, it's kind of a done deal, and hopefully you're far enough away where it's not an issue. Just showing you some of the things that were happening in Nashville. Everything that's happening right now, I think important is out on the streets, and that's where I think we need to be, despite the COVID risks. Here's our first clinic in Minneapolis in August. We're about 6 blocks from where all this stuff happened with George Floyd, where they've made they've kind of blocked off some streets and made it kind of a major place that folks congregate now in Minneapolis. You can see some of the destruction is unbelievable in Minneapolis. A lot of it's probably still there. I think 1,500 businesses were affected. Here on the right is a University of Minnesota student that she's actually as kind of our lead student, vet student liaison. She's working with this guy on the left, and she's pretty close. And yeah, look what's happened. His mask has dropped. We see a lot of masks just covering the mouth. Those are probably worse than no mouth mask at all because of that airflow through the nose where COVID virus cells like to hang out. Oh, yeah, a little note about University of Minnesota mascot. I show that for other vet students. Real quickly, risk of zoonotic disease among folks living with their pets is significant. This fellow was living in a van. He had a chicken, wasn't laying any eggs anymore. Chicken was sick, upper respiratory. This cat here had alopecia of the tail base. Did a skin scraping. We found this Sarcoptes mite, and then the gentleman himself, this is what his arms looked like. He was really, really paralytic. He didn't have enough money to wash his bedding or buy new bedding. So I think we gave him $20 and he went off to Walmart and got bedding. And then I started treating these animals and he disappeared. So I never really saw him again. And that's also typical of one of the challenges we have. This is more of a vet student question, but I'd say it's also a medical question too, to make sure we all know what these little bugs do as far as which species cross over. And it turns out that lice generally will stay with the same species. So most likely a person with lice did not get it from their pet. However, mites will cross over, just as we saw in that last slide. Fleas and ticks are kind of co-parasites. They can, obviously a tick doesn't necessarily go from a dog to a person, but if there's ticks on the dog, there's a good chance that that person might have them too. So it's really important to check because they do get the same diseases that are carried by ticks. A crude graph of the public health risks that just shows that the longer someone is outside with their pet or that pet is outside, the higher their risk, especially for bite wound risk. And that's why we're so focused on doing rabies shots. So, we say rabies is job one, not because rabies is a high risk in the United States, but because of the economic and legal fallout is pretty significant for folks. Their dogs will get confiscated. And because they can't quarantine them at home, since there is no home, they get quarantined in a shelter. And folks have talked to us, they usually owe about $250 at least after that week. So we're trying to make sure they all got rabies tags and they're caught up. And talk about whether, life on the street, how hard it is. And for some folks, they do have a pretty good setup, like that last picture I showed you. It looks like these guys are actually getting along, and their pets certainly seem fat and happy. Just kind of an overview of why these pets are important is that they provide purpose in otherwise purposeless lives. And it's probably just best to summarize it there. I'm going to go through these slides quickly because I don't want to cut into our time too much. Women living on the street have a tough go of it in Las Vegas. These folks are living in tunnels that go under the freeway. There's no lighting under there. It's just a photographer. Many of them do have pets. They get washed out every year with big gully washers once or twice a year. There's been some drownings and they go back in. North Las Vegas, thousands of homeless folks there, big homeless connect events, despair on the streets. There was a serial killer around when we were doing a street clinic there, and that was 3 years ago. You can just see the despair on this lady's face. Probably a key slide just for when we talk to people about what we do, which dog here has the better life, and I'd probably argue the one on the left does, because they are with their owner 24/7. They're active, they're socialized, and they're well taken care of. Most of the pets we see are in really good body condition score. It's very rare to see one that's thin. If anything, they could be a little overweight. And my thought would be is we could take this dog from the shelter that you see on the right here and put him with a good owner like this on the left. That could be really beneficial in a number of ways, but I can assure you that most shelters would never place a pet with a homeless person for lots of reasons. Dogs navigate trust. They navigate through streets in a city where you've never been there before. Here we have a dog. We didn't realize this fellow was blind until we worked with him for a little while, street clinic in Denver. And he has his little Dachshund Chihuahua mix, his self-trained seeing eye dog, because somehow he fell through the cracks. He isn't getting the care he needs. Traumatic brain injury, lots of studies showing that that's really prevalent among the chronically homeless. And we already talked about, obviously, good information about addiction on the streets, and alcohol can certainly be a big part of it. The recent study came out of Boston showing that if someone lived outside on the street, they were 3 times more likely to die than someone that was living in a homeless shelter, and 10 times more likely to die than a citizen in Massachusetts. Here's some stuff happening in New York City. These are just kind of some fun pictures, but we worked in Lower Greenwich Village. I wanted to show you this picture of this van. They're doing HIV testing and some blood pressure, some medical stuff. So this is kind of what One Health looks like on the street. And here we are on the sidewalk outside Graffiti Church where we did it. Our veterinary group is trying to collaborate with some of the doctors that are part of this Street Medicine Institute. These are doctors from all over the world that do nothing but street medicine. Here's a group from in Washington, D.C. doing some street medicine. And here's a picture from our little team in Philadelphia working in Park. You can see it's not that different. So why not do this stuff at the same time? Here's some at University of Illinois students in Chicago. More folks in Chicago. And we have a doctor that works with night ministry and goes out on their health van every Sunday night to a couple different locations. Here's Detroit Street Medicine again. There's about 60 street medicine teams in the United States. Sometimes I mentioned we do encampment work. On the left here is some encampments along Santa Ana River. Those have been shut down now completely because of public health risks. And the encampments in Indianapolis. Here's our vet working with USC Medical School in Bakersfield. Mentioned that street medicine clinic. And then maybe this, as far as a picture being, this is probably One Health right in action out at University of California, Davis Vet School. The students run a couple of clinics out there. And this is, so I'm going to go back to this. This is kind of our dream. We want to put together a One Health team, and on weekends, it's be all volunteers, but these are going to be top, even some top specialists in their field. Obviously, public health, social workers, addiction counselors, dentists, veterinarians, medical students, nurse practitioners, veterinary dentists, the whole team. This will not be a clinic itself. We're going to set up, use tents and tables to set up a mobile clinic, but this is where we're going to ride and have all our supplies and have a one room that's cordoned off for a private office for consults. So it's kind of our project we're working on. I'm going to stop there, but I did want to mention that co-sheltering is another big issue, and I already mentioned it, but this is a shelter, a domestic violence shelter in North Las Vegas. Was one of the first ones where women can have their pets with them. The pets do stay in a separate building, this Noah's Animal House, which is actually adjoining the women's shelter, and women can spend time in these cuddle rooms as much time as they want with their pets. So they let me in there. One thing that happened is they actually had a big upper respiratory outbreak among their cats. They also have dogs and dog runs, but their cats were housed too closely together, and I had to help the technician there figure out some antiviral strategies to keep a couple of those cats were actually really critical condition. We had to put them on IVs with antivirals and IV antibiotics, and they made it through, but imagine how devastating that would have been if they had died to the somewhat fragile emotional condition that the women may have going into that facility. Anyway, I'm going to stop there because I've probably gone on a little bit too long, but I did want to just kind of tell you about what we're about and some of the issues.
Awesome. Thank you so much, both of you. So we can move into the moderated questions now. Our first question is, can each of you discuss some of the ways the COVID-19 pandemic has impacted program delivery and community outreach? Lawson, if you want to start, we can just switch off.
Sure, it's had a huge impact. So we were doing our outreach in our mobile clinic, and Dr. Geller, we need to talk offline. I love what you're doing, and I think we need a clinic here. That caravan of health and healing that you have sounds beautiful. So one of the things it's done for us is it's slowed down our street outreach. We're luckily in a pretty urban environment here for Southwest Virginia, fairly urban environment. So we have a lot of our folks built into our community, but it slowed that outreach down. We've had to ask folks to wear masks. We've had kind of some hit and miss success with that. Same thing that Dr. Geller pointed out in the photos, right? We don't have a whole lot of space. We do run a day shelter. If folks don't have anywhere else to go, we have a place where they can have Wi-Fi, which gives them access to telemedicine appointments for things like Suboxone groups, things like that. So, I mean, it's been tough to kind of navigate the recommendations and the pragmatics of life with the population that we are and serve. So it's lessened the outreach, the public outreach that we do. It's changed some of the things that we do in the office as much as we can. We have installed a hand washing station, and we have hand sanitizer everywhere. We have masks available for folks if that's their choice to use them. But it's been delicate because, I mean, these are folks who get crapped on everywhere they go, and I don't want to turn them away because they're not willing to wear a mask. I know I have to protect the folks that we work with, and so we ask people to do that. But if that's their choice, we try to have as much of a welcoming environment as we can.
And I would definitely agree with that fine line between trying to maintain as safe an environment as you can, especially for your volunteers who might be at risk, some high risk, and for the folks that you're taking care of, you don't want to withhold care just because they're not willing to wear a mask. So even though we provide masks and we ask people to wear the mask, we will set up tables, white tables that allow kind of create a space that we have our space where we're working with the pets, and they're right outside the table. So we want to be able to talk to them, be really transparent. Usually, we recruit them to help us hold pets, and sometimes that still happens. And then, as you saw in the pictures, those masks might end up coming down. And so the folks that work on our team, I think, they're aware of the risk, and they've chosen, like I have to accept those risks. But I will say that at least probably half our team, especially in places like, these hot zones like Houston, San Diego, some in Florida too, depending on what's going on at the time, they said, the risk is really too great. Many of these pets just need preventive care and can wait. And so it becomes kind of a personal decision. But I think it's really hard to deliver street medicine and street services with COVID. It's really tough. Luckily, as far as I know, we haven't had any positives that have come out of our clinic, so I'm not actually sure of that. And I don't think that we're really turning any corners, so expect that those risky conditions to continue.
Right. And as a follow-up to that, what adjustments have volunteers within your organization had to make in order to stay safe? And has the pandemic had an impact on the number of volunteers or staff your organization has? Either one. Lawson, if you want to.
Yeah. So it has decreased the number of volunteers we have because people are afraid to come out. A lot of harm reduction work is manual. It is packing the Lawson kits. It is packing safer use kits. Even though the vehicle of harm reduction is the personal interaction, like that's the healing moment, those are the things that are necessary to prevent death and infection. And those things take a lot of time. So it's cut down the folks who come into the office, the folks that do wear masks, take precaution. We're wearing gloves when we're assembling those things. And I'm never going to ask somebody to put themselves into a situation where they feel uncomfortable. So, and I honor that when somebody says, I don't feel comfortable coming to the office to help anymore. Like, I appreciate that. I appreciate you looking after your health. So yes, it's cut that down. We've asked folks to wear protection when they come into the office, when they're around the events, things like that. But it's cut down. And I think, I don't think that that's unique to, a volunteer's perspective. I think, many of us aren't going to the same places we like to go to and do the things that we like to do. But it has hurt us because that is such a manual endeavor.
I would agree with Lawson. Also, I think I already kind of mentioned that a lot of our volunteers have just pulled back, and we totally respect that. And I think it does become a personal decision. But we have the liberty of making that decision, and the people on the other end don't really. They or their pet may really need care, and so I think that there's risks in life, and some of us have our own internal risk meters. So as far as our volunteers, we just love anybody that's willing to do it, but totally accepting when that's not able. And we're trying to manage the risk, and the street already alluded to it. It's very difficult. You could be 6 foot away from someone and you've washed your hands and wearing a mask, but if you're vaccinating their dog and their dog cries out, they might think that they need to comfort their dog, and so they'll rush in, and then suddenly they're right next to you, their face right next to you, and their mask gets down. So stuff like that happens, and I think that risk control in the streets is challenging, and there'll never be a complete elimination of that risk.
Thank you for sharing. This is another question for both of you. How have you seen the pandemic further exacerbate the inequities faced by the population your programs work with? So Lawson, if you want to start again.
Well, I don't want to, I think Dr. Geller and I probably cover some of the same things. I'll go to the specific substance use piece. There are some unhoused problems, I think, with folks getting into those. But with substance use, getting somebody into, say, residential treatment becomes a significant hassle, especially because they've got to quarantine to some degree. We've got to get them a test. It becomes a process that has you know, we've got more need than we do providers already, and then adding more hurdles to that then cuts out the folks who can't jump those. So what you've got are the folks with means who are able to jump through those hurdles, get to that treatment, to the care that they want. It's also prevented, you know, the hepatitis C treatment that we were doing. We had access through telemedicine to UVA's program, which is amazing. They know how to work with our folks, and the staff there at New River Valley knew how to work with our folks. The problem here was that COVID, the health department had to pivot and shift their attention to COVID. Understandably, that's a public health agency, that's what they need to do. But it's limited our access to get folks treated for hepatitis C. And that's happened in any sort of care or referral situation where we have somebody who says, I need something. And that's why it's been hard. I think Dr. Geller spoke to it, like most of our folks get denied places they go. And so like trying to do that again in our services, it's just kind of a no-go. But it is certainly put in place more barriers that folks were already, you know, for people who are already facing barriers. And that's been difficult for us.
Yeah, and I'd echo that again. But you know, if you remember that first slide I showed you, this fellow with a couple big dogs and his cart. You know, he's not gonna roll into some doctor's office or some hospital. It's gonna be hard for him to get testing. Not only that, access to information is what we're seeing as a big problem. Like some people do have phones, but very few of them have really great internet access, and not too many of them have the knowledge to use those phones effectively as far as like surfing the net, etc. We kind of all take that for granted somewhat, because so they might be given a free phone, but they may or may not have access to Wi-Fi, you know, or a hotspot. And if you understand how that works. So they don't know much about COVID. I mean, that's just general discussions we're having. You know, they talk about the virus, and so I think that's really a challenge. They don't know about our street clinics because they don't have phones, so it's hard for them to find out about it. And even if there is COVID testing, many of the shelters that we go to where people have pets, they aren't not allowed in the door unless they have a service animal. So access to care has been magnified by COVID, I would say. And because of the increased kind of strife on the streets and hardship, I think retrospective studies are going to show an increase in suicide rate, especially among those that are living outside. And so we are really, we all got some training in something called QPR training, which is called Question, Persuade, Refer, because we have had folks express to us that, you know, they would like to end their lives. And in many cases they'll say, and my pet is the only thing that stopped me from doing it. So that risk is magnified also, I think.
So Dr. Geller's talked about a few things there. Deaths of despair. I think we talk a lot about COVID, but we as a culture, at least the folks that we work with, you know, had a shit go of it beforehand. And so now life is harder, right? So I think deaths of despair is a huge piece of what's happening. And I think one of the moves that COVID has brought that's been positive on the whole is the approach and the loosening of telemedicine guidelines. That's been amazing, should have happened way before this. But Dr. Geller points out, and this is the case with the folks that we serve, to have access to telemedicine, you have to have a device that has internet connection. If folks have a phone, number one, and it wasn't stolen last night when they nodded off, they probably don't have minutes on it. If they don't have minutes on it, they're probably not at a place regularly, unless it's at our office, that has Wi-Fi access or some public place where they often get shooed away from, right? So, I mean, so the windfall of access has been amazing, and it should have happened a long time ago. The problem is it's still not getting down to the folks that we work with on a daily basis, because they don't have the things that all of us here probably take for granted, which is, you know, a cell phone that I can check my email on. And that's not something that the folks we work with have access to often.
Yeah, we got to figure something out on that, Lawson.
This next question is specific to you, Lawson. How have you seen addiction, substance use, or recovery change due to the pandemic?
You know, I had a conversation with somebody the other day, and they were talking, and it was a reporter, and they kept bringing up COVID and bringing up COVID, and COVID complicates a situation that was already messed up, is what it does. I think, I mean, as a culture, like even through today, right? There's a lot of cortisone in the air, man. There's a lot of anxiety. There's a lot of anxiety about how things are going to go the rest of this week. There's a lot of anxiety about an illness that nobody can see, but people hear people are dying from. You know, not everybody has direct relationship to it yet. We were already in a place where, yeah, the stock market's going up, but nobody's, you know, I can't get a job for this person over here, or these 23 people over here, right? So, and if they have a job, they haven't gotten a raise in years, or never, maybe. So, I mean, we already had a really stressful situation in life, and then what we've done is compounded it. So, you know, when what I didn't do in this presentation that I do often is ask, you know, audience members why people use drugs. Why do people use drugs? Why do people use, you know, what is it? And the idea is to kind of get around to the fact that we all use drugs. I used 3 stimulants this morning to get ready for work, right? My cups of coffee. I use nicotine. We'll talk about stages of change and where I am with that later. But like, it's a stress response. Substance use is often a stress response. And when you've got a world that looks the way it does outside today, you know, with a pandemic, with a populace that's not sure of where things are going, substance use goes up, right? So I like I said, at the end of the spring, we had 500 people enrolled in our service. Now we're going to hit 1,100. So yes, it's up. But I hate to blame it on COVID. I think without COVID here, we would still see some of the trends that we've got going on. It's not that it's not the causal factor for all of this. It is a complicating factor. As far as recovery, I think, so I guess to start from a baseline, we have a broad definition of recovery. We use SAMHSA, right? Which is a person who's able to live a self-directed life, improves their health. But it doesn't mention anything about substance use. So if somebody's making positive changes in their life and they're using substances, like moving from sharing syringes to using a single one, we celebrate that as any positive change. We consider that recovery. For traditional recovery, through things like Oxford houses, it's been difficult because, again, people have to get tested. They have to have, you know, certain quarantine things to follow in order to get into that housing. So it's complicated and made it difficult. It also made, you know, as somebody who's in long-term recovery myself, you know, in the traditional 12-step models, which, you know, I have that's a long conversation. But in the traditional 12-step models, you couldn't have a space to have a meeting, right? So having to move to online, then again, moved a section of people who could do it, right? Who had that access and could do it up into that piece and gave them that privilege. You know, they enjoyed that privilege to make those meetings. The other section of folks who are interested in finding recovery through that route, who didn't have phones, who couldn't access it, were left out to dry, hung out to dry. So those are the things I've seen. And I'm trying to remember, Jackie, this is kind of back at you with the surveys we did. like, I mean, I remember seeing in some instances, and this is anecdotal in my mind as I'm going through it, where people talked about either increases or decreases in substance use, but most of them were saying it's about the same, if I'm not mistaken.
Yeah, I think that's what I gathered from the survey that we did, is it did vary from person to person. Some people were consistently comfortable with the amount that they were using, and some people the stress was too much and they did relapse. So it definitely varied.
So that's, I mean, that's what I've seen through this. I think COVID's a fun thing to blame all of this on, but I think most of it would be here without those headlines and without that virus.
So the next question I have is for Dr. Geller. And the question is, what do you want people to know about the relationship between pets and homelessness that they may not be aware of? And has COVID had a notable impact on the human-animal bond, either positive or negative?
Well, yeah, that's a good question. There's definitely a stigma. I mean, there's a stigma about being homeless, right? And a lot of folks actually don't think people that are living outside should have pets if they're not responsible. And I tried to argue very briefly in my presentation that it's possible, you could argue that the pets that are actually living outside with their owners 24/7, and they are well fed and well taken care of, and they can get basic vet care, are living probably better lives than our pets that might be sleeping on the couch a good part of the day, and maybe getting a little bit overweight. But for the people on the street, the reason that, they already have so many barriers already, and now we're adding additional barriers. They can't get on a bus. We looked at transportation systems in 50 biggest cities in the United States, and only 3 cities allow pets on a leash, larger pets on a leash of any size, to ride on the bus. They'll have to be either small or it has to be a service dog, and 10 cities don't allow pets at all. Detroit would be one example. So I mean, that's a big barrier right there. Just, you can't even get any place. And so I think people don't really think about that necessarily. And of course, we talked about already not being able to go through doors, go through for a job interview, maybe get a shower, just use the bathroom, doctor's appointment, medical checkup, even go to 7-Eleven, get a cup of coffee. Yeah, maybe you can get someone to watch your dogs for you. So people on the street that have pets, number one, they take really good care of them and put them ahead of themselves. And number two, they're willing to do that, even though it makes their own lives even harder. And then the reason they do that is because it provides a purpose, to often what is otherwise a purposeless life.
So this next question is for both of you. Is there a silver lining to the COVID pandemic relative to how it has changed the work you do, or any future impact you believe it will have on the populations you work with?
I don't know that it's going to have a silver lining directly for the folks that we work with in our programs. But I think there's an indirect silver lining, and that's the relationships we've built through this, through our public health approach. Roanoke Health Department was under new management now, and that's been good. But those relationships that we built with Dr. Bissell in the New River Valley, now with Dr. Odell here in the Roanoke Allegheny Health Department, those in not only being trusted to do the work, but being asked in situations where there are other people to ask to do the work, having that kind of being able to back up the ask with the work that we've done, I think has put us in a good position as an organization, at least here regionally, to be able to bring those folks further in to our conversation about the folks that we serve. Not that, I'm already speaking to, luckily, a friendly audience, right? But to be able to show those folks what we do and who we do it with, and give them that exposure to that, I think can only help bring resources to bear there. So I think that's the silver lining for us, or the relationships that we developed over the course of this virus and continue to.
Yeah, it's hard for me to come up with too many positives out of it, but except that, you know, and this is an expression that's way overused. Of course, we're all in this together. But I think, you know, there's another common denominator between us and the folks that we're working with on the street. We both face that risk equally, and it can affect any of us. So, and I think it has led to more collaboration, because I think we're seeing some folks that are really making special efforts to provide additional services. They realize, you know, we may be sequestered at home, but I think some folks kind of hear the calling, hey, it's got to be tough out there, you know, living in a tent city, for example, or sleeping on the sidewalk. Even if I, you know, going out and giving out some socks, they might be inspired to do that because of this additional difficulty in everyone's lives.
So that looks like it's the end of our prepared questions. And now we just have some time to answer any questions that the audience has, which it looks like there's a few. The first question is, how can we get involved with your organizations? The person said, vet student here willing to travel to be a part of these. So.
Okay, so that's a, do we know what your vet student that is?
Not sure. It doesn't have a person. It just says, but yeah, I'm not sure.
Okay. Well, we are kind of the new thing we're doing now is trying to encourage vet students. Really seem to be passionate about this, and I'm really, really impressed by that. I think it's kind of a new thing. A veterinarian's job, been practicing for 20, 30 years. Kind of go to work, do your job, get paid, and go home. It's a little bit like that. So there's lots of ways for vet students to get involved locally and nationally, and including we've had vet students that we've helped with travel costs so they could go to a big clinic like when we did in Chicago, or last month where we had over 500 pets, people waiting on the streets for 6, 7, 8 hours to get their pets taken care of. Sometimes it's just a few vaccines. And so I would just encourage any students that are interested in how they can get involved to contact us easily through the website. All you have to do is remember the words, the Street Dog Coalition. Website pops up, there's contact, or the streetdogcoalition@gmail.com, which actually comes to me. And one thing we could do pretty easily is help you guys set up a street medicine club at the vet school. And to me, I know you have a One Health group going, but this could be more of an activist group. Goes out on the streets.
Sounds awesome. I will definitely be in contact with you about that, and any vet students who are on here who want to reach out to me, feel free, and I can be a liaison between these two groups as well. And if they don't want to reach out to you individually, or if we want to start something here in Virginia.
We want to be a part of it too. I'm
yes.
inspired by Dr. Geller's work.
Absolutely.
And I actually have 2 small dogs that I adopted because one of the folks we were working with got housing and couldn't take them with her as a condition of that. Oh. So they go, I would show them off, but they're both hidden under a blanket after a long day of work at the office. They come to the office with us. And, you know, as some of y'all are going to be MPH, some of y'all are vet students, but, you know, if you need something that will help ease an intake or, you know, kind of an appointment, get some dogs in the office. It is made, you know, folks come to us and they're suspicious, right? You're going to help me. They are scared, they're anxious. And when one of these 2 little ones jump in their lap, it changes the conversation immediately. So anyway, I'm inspired by Dr. Geller's work. And if anybody gets something like that going around here, we've got plenty of folks we can connect you with. We'd love to be on your outreach with you. Love to have you with us.
That sounds great, Lawson. We can make that happen. That's kind of what we're working on. And, you know, just another comment about a pet. You know, the medical groups we're working with have already commented that people sometimes aren't real thrilled about a doctor, you know, medical student coming up to them and saying, hey, yeah, I want to take care of you medically or take care of your medical problems. Like there is a lot of distrust there. The medical folks have learned how to create trust. One of the ways they do that is by literally getting down low, sitting down on the sidewalk and talking to folks, trying to recreate that relationship. But if there's a pet, that is a connection as a veterinary team we can make immediately. What's your pet's name? Let's take care of him. Does he have any problems? I mean, people, it's just a point of connection. And then it allows, say, medical folks or a social worker or addiction counselor to get involved more easily by using that pet as a connector. And so that's why I think actually veterinarians could be kind of on the front line of some of these street medicine outreaches, but it definitely needs to be a team. I can't tell you how many times, we've been in over our heads with someone, they start talking to us about some stuff that's going on. We're really glad that we have Fred with us some of the time, but not always.
Going off of how people can get more involved, Lawson, can you speak about the ways that students and members of the community can help your organization or engage with these issues in general?
Yeah, a lot of ways. Like I said, harm reduction is manual work. If you've got a few hours to kill, come hang out with us in the rooms and put together some naloxone kits. Everyone you touch is going to save a life. They get used. The other piece is, man, y'all organizing and being a part of the Street Dog Coalition. I would love to have that here in Southwest Virginia. I know Roanoke is, again, having this conversation today at lunch, Roanoke's an interesting place because I think we have an outsized population of folks who are unhoused because we have resources and folks literally buy suitcases and bus tickets to send folks here. So we do have, I think, the need here for folks, and I do see them often. They come in our office, folks with pets. And I think that, anyway, so, as far as getting involved, I'm excited about that work. I want to be a part of it. It's really tough now with COVID to be a part of what VHRC is doing. On an advocacy level, voting just happened, but like helping folks and looking at people who care, right? People who care about the populations we work with. And some people get it and some people don't. Helping us, we had students from Virginia Tech School of Medicine help us this year with our push to change some of the legislation around harm reduction and overdose reporting. And that was key and vital. So being a part of those pushes, we don't have the same coalition going into 2021 because we're all trying to put together and do our homework for the laws we just passed. But, with those sorts of pushes, we certainly need the help, the person power, the brain power, and folks putting together kits.
By the way, we have a team in Richmond, and we're doing, I think that's probably pretty far from you guys, but she's doing a street clinic up there, I think December 5th. But all we need to get something going, is we try to make this pretty easy. As a veterinarian with, it's got a little bit of fire going on in his or her belly, and everything else is supplied. So from an action point of view, action step to get something going, if you perceive that as a need or some interest, that's all we need is that license DVM. I'd come and do it, except I'm not licensed there. And so I'd just be a helper like any of you guys.
So we have one more question just to kind of finish it off. Someone asked, as COVID-related legislation and regulations evolve, are there any things involving the populations you all work with that the community should be aware of?
I haven't thought through that far yet. I think in anticipation of what's coming, I haven't seen anything being generated, but we have to keep in mind, number one, whether we think it's a smart decision or not for somebody to make whatever choice they're going to make. Wear a mask, take a substance, not take a housing appointment to live inside versus living outside. That those individuals have self-agency to make those determinations. Not all of them have the resources to comply with requirements. So, I mean, if we're going to require masks, we've got to hand out masks, and we got to hand out so many that if somebody walks up to the door, they don't have to worry about having it in their pocket. They should be able to pick one up, because most folks, most of the folks we work with, having personal property is difficult. It gets stolen a lot, or you get to a point where you can't carry it all, right? And of all the vital things I need in my pack, the mask isn't always one of them. So I think we need to consider, if we're going to require things, we need to fund the resources to support them. And I think that goes for almost any legislation. So that's kind of a cop out, but when I think about our folks, when I think about possible legislation, if we're going to make the ask, we've got to supply people with the tools.
Now, I might comment that, we call a stay-at-home order. What does that mean for someone that doesn't really have a home?
Yeah.
And then, because folks have told me, well, I don't even have any place, because at least where I'm at, the shelters all shut down for a while, so folks couldn't even go and get warm. There were emergency shelters at night, but still people with pets, by the way, weren't allowed in them. So, they just figure out how to sleep outside. But they would typically go to places like a library to get warm, and now the libraries are shut down. And so I think it's these regulations, really negatively impact folks that are living outside, and it comes back to just making hard life even harder. And I agree about, there should be masks, at the entrance of every businesses, there should be a box of masks and hand sanitizers. And probably should be paid for by the health department, not necessarily by those businesses, if that's a requirement.
That's a good point with the stay-at-home order, which is what kind of got us rolling in the COVID testing in general. Was like, most of our folks don't have a place to isolate. Most of our, so what are we going to do? They're going to be exposed.
So I'm going to just jump in here because we're getting close to the end. And I wanted to say that this conversation has been so great to hear. So I actually, when I was still doing a lot of clinical work, I was on a board of directors in Gainesville, Florida for the St. Francis Pet Care Clinic. And we provided free pet care to the pets of homeless and low-income individuals in our county. And that was probably the most rewarding experience of my life, for sure, one of them. And is what sort of drove me into this interest in the links between veterinary health and public health. And so to be have progressed in my career and be in this different location and to see students coming together and having you two as speakers talking about these issues, it's just has been a really great joy for me to hear this. And then also to hear the excitement of thinking about how do we take this opportunity for communication and then move that forward to say, well, what are our community needs and how can we join together? And we offer the great opportunity here at our college because we have vet students and we have MPH students, and who doesn't love animals? And who doesn't, I think we have a lot of compassion in the fields of public health and veterinary medicine, and this is a great way to think about how we can merge them. So I really appreciate both of you speaking tonight and sharing with us. Thank you, Memi, and thank you, Jackie, for the questions. Thanks to everyone who is watching out there. And then, as I said, this will be recorded, so hopefully we'll be able to get more people interested and engaged. But anyway, thank you all so much. Any final comments?
Well, thanks to you guys for putting this on, and Lawson, look for email from me. We'll get in touch.
Yeah, I also appreciate you all putting this together. I appreciate the work that Jackie has done with us and helped our community with. And I'm inspired and excited by Dr. Geller's work. I had no clue had absolutely no clue, and hope we can work to bring that here to Southwest Virginia.
Oh, well, thanks for those kind words. Appreciate it.
All right. Thanks, guys. Everybody have a great night. Hopefully
Bye
we
all.
can reduce that cortisol level.
Bye.
Bye.